biopsy become redundant today, so which plays a very important role in the histopathology. So he will speak upon that. Please, Dr. Jayant Hota.
Thank you, sir, for your kind words. And I thank the organizers, especially Dr. Himanshu Verma and Dr. Mahinder, for giving me, if not a controversial, maybe a contentious topic, but I have done some 2-3 smart things over here. One is, this is not a statement, this is a question: has kidney biopsy become redundant today? And I've deliberately put 2 queries. Actually, in English, there is no, you can't put 2 queries together. But there is a very strange relation as far as the Amitabh Bachchan movies goes, कि अंग्रेजी शब्द पुलिंग है कि स्त्रीलिंग है जब तक डिसाइड करते यूपी ने हड़प अंग्रेज लोगों ने हड़प कर दिया यूपी. So there is a very strange relation with English and UP. So I have deliberately put 2 queries, and at the end of the talk, if I can remove at least one of them, so I'll be very happy and I'll think I've done a good job. And another thing is, usually I put my alma mater Apollo, Indraprastha Apollo Hospital's picture in my first slide, but here I have put a kind of cartoon. Okay, so even if I'm mocked at the end of the talk, at least my hospital will be spared. Now coming to the broad headlines, so we'll be discussing in maybe next 10-15 minutes indications of kidney biopsy, what are the non-invasive way to approach different kidney diseases, some new gen assays, how they are going to help us without a biopsy, and then finally I'll be concluding. Now, to my mind, why do we need a kidney biopsy? For native kidney, as far as the native kidney is concerned, for the diagnosis of proteinuria, active sediments, renal dysfunctions, either individually or maybe in a combination of these 3. For optimizing the treatment, for prognosis of the underlying disease, let us say you are dealing with ANCA vasculitis or you are dealing with IgA nephropathy, if there is a lot of sclerosis, so probably you will not, kind of step up the immunosuppression. So it has got some prognostic value as well. And for treatment response, these days, you have to have histological remission in addition to clinical remission, especially in lupus and other things. So to my mind, these are the few indications of native kidney biopsy. And as far as the transplant kidney goes, for the diagnosis of obviously graft dysfunction, and these days BAMF have included, especially after 2017, the genetic transcripts into the biopsy. Especially if you are, kind of dealing with AMR, and if the C4D is negative, you can go for a genetic transcripts of the kidney biopsy and find out if there is some gene which can tell you whether the patient is, you are dealing with AMR. And third is recurrence of the native disease. So these are, to my mind, some of the indications of kidney biopsy. Now coming to, this is a very busy slide. Now coming to when a patient comes to our clinic, what do we do? First is we take a good history, and in the history only we make out a lot of things, whether the patient is having some infective kidney disease, whether it is some metabolic kidney disease, a lot of things we make out. And then what you do is you go for a good ultrasound. And in the ultrasound, you can again, screen out a lot of things, like for example, whether you are dealing with ADPKD, K-cut, obstructive uropathy, single kidney, or other combination of some disease. And then you come up with 3 things. There can be GFR loss, there will be proteinuria, and there will be glomerular hematuria. So, I don't know. Sorry. Okay, so if you are dealing with GFR loss, so what are your possibilities? The young chap has come to your clinic with a creatine of, let us say, 2, and urine routine showing 1 or 2 plus protein with a little bit of sediments. So what are the duties? It can be probably you are dealing with IgA nephropathy, or it can be some vasculitis, or there can be TMA, wood pastures, MPG and C3G conundrum, or maybe diabetic or hypertensive kidney disease. And you just look at, this slide, you just look at. If you are dealing with IgA nephropathy and if somehow you can find out, there is under-galactosylation of the IgA, so probably your diagnosis is done. Similarly, if you are thinking that the patient might be having ANCA vasculitis and on the top of that, the ANCA titer is very high, especially PR3, then probably you are dealing with ANCA vasculitis because they have a very high, predictive rate. Similarly, if you are thinking of lupus and the, ANA and DSDNA is positive, then probably you are dealing with the lupus nephritis. So similarly, let us say somebody has got proteinuria, only proteinuria, nephrotic or non-nephrotic proteinuria. There is no active sediments, or even if they are, they are very little. So what are the differential? It can be DKD, it can be membranous, it can be MCD, FSGS conundrum, or it can be amyloidosis, depending on the, the history. The patient is diabetic, bland sediments, protein 3 plus. I don't have to, and go for a fun test. Look at the diabetic retinopathy. So probably you are dealing with diabetic kidney disease. Everybody treats diabetic kidney disease without a biopsy. Similarly, we can diagnose membranous nephropathy, MCD, FSGS, amyloidosis, and other things depending on what is the type of clinical scenario we are dealing with. And if the patient has glomerular hematuria, then what are the differentials? And according to differential, if you take a good, look at the differential, there are genetic assays these days, and if you can go for a C, MS, IG, undergalactosis, nothing like that. So up to the end of this slide, probably I can stop the, discussion. But just to, because I've been given some time, so just to, keep you engaged. So this is the one. These days we have forgotten urine examination most of the time. In our, when we were students, our professor used to ask us to go and do the urine test yourself. But you see, we are forgetting a very important and almost like a mirror of, kidney disease. Now this is a very important slide, though it is a transplant slide, but you can just see, at the time, the beginning of the disease, somebody has received a kidney transplantation, okay, and over a period of time, there may be subclinical rejections. That will be followed by the, the pouring in of all the biomarkers, both in urine and blood, and that will be followed by the clinical rejections. Where do you do a biopsy? You do a biopsy when the patient has got clinical rejection. You don't do a biopsy when the patient has, unless you have got a protocol biopsy that nobody does in a live transplant, okay? So you can't pick up. But look at the transcriptomics, look at the proteomics, look at the metabolomics. You can pick up early transplant rejection and graft dysfunction, okay? And you can do a lot of things. So the transplant, you can see, in the transplantation, the author has said, allograft biopsy has become the corpus standard for allograft dysfunction. He has used the word corpus standard. We have heard of gold standard, but never heard of this word. This is the editorial. It says allograft biopsy has become the corpus standard for allograft dysfunction. This slide, for the lack of a better slide, this slide can be extrapolated into the native kidney disease. Just imagine somebody has got IgA nephropathy. If patient doesn't come to your clinic the day patient develops IgA nephropathy, the patient must be having IgA nephropathy for quite some time before you intervene, before you do a biopsy. Okay? So, in our last conference, Dr. Mohit Mathur, who is doing a lot of work on IgA nephropathy, he was telling how much we are missing on IgA nephropathy, and the patients are developing end-stage kidney disease. That is because there is no screening. We are missing out on a good chunk of IgA nephropathy patient, and by the time you do a biopsy, your MST score will say M0, E0, S0, S1, T1, C0. You can't do anything now. Okay? So we are missing this slide can be extrapolated into the native kidney disease. I know I'm missing out a lot of patients. That is because we are not doing enough of the screening. Now if the time permits, we can discuss some of the diseases, like for example MCD. Everybody is well trained in MCD. At least this is one disease where you don't need a biopsy if the patient fits into that particular age group. Okay, if somebody is 2 to 8, 10 or 8 to 10 years old child, you do diagnose MCD, and you do treat MCD patients. You treat resistant MCD, steroid-dependent MCD, and we don't need a biopsy in that case. Nowadays, what has happened is, initially we were thinking that MCD is a T-cell disease. Even if there is, it is a bland disease, there is activation of the T cells. But nowadays, we have found out one anti-nephrin antibodies, and which is very specific to MCD. It is not seen in FSGS. So those people who think that MCD and FSGS are almost the same entity, now it is clear that MCD is a different disease and FSGS is a very different disease. Unfortunately, what happens, let us say there is a patient of FSGS. Okay, you have taken a sample, and let us say the sample is not showing anything. So the biopsy, the last sentence of the biopsy will be, however, you can't rule out the unsampled foci of FSGS. And then you are left with nothing. The biopsy is showing MCD, but you are not sure whether you have left out on the unsampled quote-unquote FSGS. What will you do? So what you can do is you just look at the urinary CD80. If the urinary CD80 is significantly high, it says MCD. This is one particular urinary marker which can differentiate MCD and FSGS. Nobody can differentiate MCD FSGS in the biopsy if you have not taken the that particular sample. Okay, And there's one anti-nephrin antibodies. Let us say in the Neptune study cohort, what they have done is they have taken the anti-nephrin antibodies in the MCD cohort and in the other nephrotic cohort, and they have found that in more than 98% cases it is negative. Anti-nephrin is negative. Okay. Similarly, there is a biomarker that consists of vitamin D binding protein, adiponectin, matrix metalloproteinate 2 that significantly predict steroid resistance. No biopsy can tell you this particular patient is going to be steroid resistant or steroid sensitive. So here you can predict steroid resistance beforehand. Okay, so that you can be prepared for the second line or third line drugs. Similarly, FSGS, we all know about SUPAR and CLCF1, but nowadays there are newer molecules coming up. Okay, one is ApoA1B, the modified form of apolipoprotein that increases in recurrent FSGS after transplant. Similarly, MI, the microRNA 193A, which increases in urinary genomics of children with primary FSGS, but not with MCD. You just see. I mean, this is one molecule which is seen in MCD. I mean, only FSGS, not like urinary CD80 is seen in MCD, but microRNA 193A is seen only in FSGS. But this test can tell you that whether you are dealing with FSGS or MCD. I mean, no biopsy can tell you if you have not taken that sample from that foci. Similarly, urine peptide-based classifiers, largely which are fragments of collagen, they can differentiate from primary. And one more, let us say you have taken a biopsy. The biopsy is showing FSGS. How will you know it is primary or secondary unless there is perihalar changes or there is subcortical infarct or glomerulomegaly or something like that. Many times the histopathologist will miss it. I mean, they will tell you, no, sir, we are not getting any, this thing of secondary FSGS. Then what will you do? I mean, I have seen n number of patients where you are not sure whether you are dealing with primary or secondary, whether you want to use immunosuppression or not use immunosuppression. This is one molecule you see can differentiate whether you are dealing with primary or secondary FSGS. Similarly, urinary proteomics analysis can serve as a non-invasive tool to evaluate the degree of renal fibrosis. Okay, and these are dynamic things. Again, you can repeat it every day, but you can't do every day. You can't do a biopsy every day or every month. Similarly, membranous nephropathy. I think this is going to be one disease probably where biopsy will be obsolete in no time. Okay, you don't need a biopsy for membranous nephropathy. Okay, the patient has come to you with a proteinuria illness. You just do plateau R. Okay, if the plateau R is more than 50, that is what the KDIGO guideline says. You are dealing with primary membranous nephropathy. I mean, period. Similarly, there's other molecules like, for example, NAIL1. Recently, there's one article in Indian Journal of Nephrology. When NAIL1 initially was thought to be associated with secondary membranous nephropathy, especially carcinoma related. But now there's a study in which they say, yes, it is related to, the NSAID-induced membranous nephropathy, even in, alternative drug-induced membranous nephropathy. So let us say the patient has come to you with a proteinuria illness, you have done NAIL1, NAIL1 is significantly positive, that means you have to find out secondary causes of membranous nephropathy. Isn't it? Let us say you have taken a biopsy. The biopsy will say membranous nephropathy. Then you don't know whether you are dealing with primary or secondary. Okay, IgA nephropathy. IgA nephropathy, what I'm doing is now I've given a thesis topic to my student. We are seeing a very strong correlation of serum IgA level with IgA nephropathy, especially if the nephropathy is active. But if you can do the galactose deficient IgA level, especially along with the antibody complex, so with 100% surety you can say that you are dealing with IgA nephropathy. There's one more molecule, the DKK3. If it is more than 779 picogram per milligram of creatinine, that was seen in STOP IgA trial, which was a trial to compare immunosuppression and no immunosuppression. They found that this molecule can even predict, what is going to happen to the IgA nephropathy patient. Any rise, fall, or stability of the DKK3 protein can tell you whether you are dealing, whether the IgA nephropathy is worsening, progressing, or it is getting stable. And there's one more molecule, this IgAN237. IgAN237, urinary IgAN237 has already been validated. Urinary IgAN237 classifier represents a risk stratification for IgA nephropathy. And in the later, and it is a very dynamic one. You can see the differentiation between progressor and non-progressor. And it is, the p-value is less than 0.001. So it is there significant. Okay? So if somebody has got IgA nephropathy and if the IgAN237 is higher, that means you are dealing with a progressive IgA nephropathy. Similarly, the MPGN, C3GN and C4GN. If you do a complement profile, if you are doing C3, C4 nephritic factor, anti-CF, factor B antibodies, then you can diagnose. Similarly, urinary, the level of blood C3 compared to the MAC level, this is the membrane attack complex. If the ratio is going down, that means the kidney disease is worsened. So similarly, lupus nephritis, there are a lot of molecules in lupus nephritis where we can probably, you can say that probably we don't need a biopsy, especially the rail. Rail has been already validated. And rail can represent an interesting non-invasive tool to determine the lupus nephritis activity. Okay, forget the activity index and chronicity index. Similarly, there are a lot of molecules coming up in ANCA-associated vasculitis. TMA, we don't need a biopsy. So if you look at the literature now, literature is studded with a lot of molecules coming up, especially one very interesting molecule is torque-tinovirus. That can tell you, if the torque-tinovirus titer is more than 10^6, then probably your graft function is doing well. So there are a lot of molecules which are coming up now. Okay, and for transplantation, I remember Dr. Mahendra how we struggle in a patient where we are not able to differentiate whether we are dealing with ATN and AMR. The C4D was negative. We had to go back to DSA to find out whether we are dealing with AMR. The biopsy was totally confusing. Okay, and now if you combine DSA and AMR, if you can if you can combine, the cell-free, do not derive cell-free DNA with DSA, then probably you don't need a biopsy. Similar for BK virus nephropathy. To differentiate between acute T-cell rejection and BK virus nephropathy, what you need is a urine peptide profile, and you can find out whether you are dealing with BK virus nephropathy or acute T-cell rejection. So to conclude, kidney biopsy is an invasive and it's a static measure of the kidney damage. You can't find out the dynamicity in the kidney biopsy. With a chance of missing out of the disease, especially if the sample is unrepresentative or inadequate renal tissue, you have find out. Whereas genomics, proteomics, transcriptomics, metabolomics are non-invasive, dynamic measure of kidney damage, which are going to replace, I think, kidney biopsy, which was once a gold standard, to now a copper standard. Thank you.
Dr. Jayant, it's a very enlightening, very exciting talk regarding these biomarkers. I personally feel probably initial to begin with a combined approach of the kidney biopsy with monitoring with these biomarkers would be a better choice to begin with. Probably in the future there could be less requirement of